This podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each person is so unique, please consult with your healthcare professional for any medical questions that you may have.
Welcome, everyone. You're listening to the second episode of the Not Your Doc podcast. I'm your host, Vanessa Diedrichson, and we're joined again by Mr. Not Your Doc himself, Dr. Charles Tadros. How you doing?
Hey, hi, Vanessa. How's your week?
It's been pretty good. Lots going on. I'm happy about the fall weather, obviously.
Yes, beautiful days.
Yeah. So, we kind of did a little bit of an overview last time, and I guess we're going to start digging into some of the good stuff today.
Yes.
We had a lot of discussion about where we should really start with this, and I think that we could, a good place to settle is the main condition that we treat here at Midwest Institute for Hearts and Minds, which is depression. Mm-hmm. So we use ketamine here to help people who've tried and failed many other treatments for their depression. And of course, we'll get to ketamine specifically a little bit later, but as we alluded to in the previous episode, like you were explaining, a lot of issues with patients understanding their diagnosis and treatments is that things just aren't explained very well.
Mm-hmm. That's right.
So I think the goal of today is just to kind of zoom the lens out and start with the basics about depression.
Yeah, sure.
So, Dr. Tadros, what is depression?
Well, people use the word depression to mean a bunch of different things, and a lot of people say they had a bad day and they're depressed, and that's not technically that's not the medical term. That's not how the medical term is used. So the word sadness or grief or loneliness or other things that are kind of negative connotations, negative feelings for mood, don't necessarily mean clinical depression or what we call major depression. For major depression, it's something that lasts 2 weeks at least, and then at least has several features, and typically low mood and loss of pleasure are some of the big components of it. There's a bunch of other things: altered sleep, increased sleep or decreased sleep; altered appetite, increased appetite or decreased appetite. Like I said, altered energy, usually not increased but decreased energy. Lack of motivation for stuff, even for fun things like playing with your kids or playing with your grandkids, going out for a fun time, and certainly that's some of the basic stuff that we see over and over again. But people typically will talk about depression in a variety of ways. But whenever it comes to treatment-resistant depression, it's clinical depression that has failed treatment. And treatment in this case is not that high of a hurdle to achieve. It's at least 2 different drugs that come to full dose, because sometimes you have to start them at low dose and ramp them up over several weeks to months, and giving it enough several weeks to months for them to work. And if a person has failed 2 different drugs, or sometimes we can consider if the 2 drugs have stopped working, even if you increase the doses to appropriate FDA-approved levels or manufacturer-approved dosings, then we can potentially call these people treatment-resistant. And typically, it's about probably 10 to 30% of people who try antidepressants, oral antidepressants, that don't respond well enough, and we can call those treatment-resistant.
Okay. All right, so let me back you up a little bit then. So and you kind of alluded to this at the beginning. Is depression a clinical diagnosis, or is it an emotion? Is it a feeling I have?
So, unlike blood pressure and cholesterol, where we can get something objective, we could put a blood pressure cuff on you and get some numbers. We don't have to ask you what your blood pressure is or your cholesterol numbers. We can get from a blood test. We don't have to ask you about your cholesterol, how you feel about your cholesterol. In a lot of mental health and psychiatry, not everything, but a lot of it is what the person looks like and behaves like and also says. So a lot of it's observational. So a lot of it is what we'll call what a lot of us will call mood or emotions. So it's a low mood, persistently low mood, and that's kind of where it starts. But it's different than a lot of other medical conditions chronic conditions that we treat.
Yeah. So I wouldn't say that I have clinical depression unless I've been diagnosed by a medical professional, and it's something more than just feeling sad from time to time, right?
Yeah. The normal ups and downs of our days, of our lives, are interacting with other people. That's not unusual. If your kids are having trouble at school, or if your mom is sick, or you're about to lose your job, a lot of that stuff is stress and sadness, but not necessarily depression. It can turn into depression, and depression can coexist with sadness, appropriate sadness, and appropriate grief. And that's where it's hard, because sometimes people say, I'm depressed and I've been on medicine, I've been doing fine, but now I feel worse because the pandemic hit. And so is it because, are you appropriately sad, or is it because your depression has gotten worse? And sometimes that's very hard to differentiate.
Yeah. So you mentioned a lot of different situations there in which people would kind of be expected to experience low mood or grief or sadness or whatever, but who gets depressed? Who's susceptible to depression?
It's everybody. Women for adults, women on average are more than men, but that are diagnosed with major depression. But anybody can be. And in the old days, we didn't think kids could become depressed, but we now know that kids can have depression. And depression doesn't always mean suicidality. People think that depression has to be severe enough to call it suicide, or severe enough to not get out of bed. And that's not true. Those are certainly extreme cases of depression that are very easy to pick up, but much milder depression that can rob you of your energy and your life and your relationships is kind of what we tend to see on average whenever we're first diagnosing depression oftentimes.
Oh, so old people, young people, children. Can animals get depression? Have we seen that in animal models?
Sure. Yes, animals can get depressed. Some of our, I don't know about amphibians and reptiles, but certainly mammals. So chimpanzees and our pets, our dogs, for instance, they can have depression. So yes.
Okay. So without getting too wonky and into medical textbook, explanations of this, can you give us just a general idea of what's happening in a depressed brain?
Yeah. So in the old days, different theories have happened over decades, and just now we've left the brain being deficient in serotonin philosophy that we've had for probably 40 years.
So that's on its way out? It's
on its way out, yeah. So now it's overactive and underactive centers of the brains, or pathways between centers of the brains. So that's the philosophy now, is that underactive and overactive pathways.
So it sounds like you're saying we don't have as exact of an explanation of how it works as we do with coronary artery disease or something like that.
That's right. We have better brain imaging, unlike heart disease, where we can ultrasound your heart and we can do dye studies of your heart. We're just now in the last few decades, in research settings only, really, looking at brains, functional MRI. We're looking at SPECT scans, single photon energy CT scans. So we're able to look at directly at the brain, or surrogate markers like blood flow to the brain centers that are underactive or overactive. But this is really experimental. I know some people are out there using it to help diagnose and treat patients, just the commercial public setting. But that's not accepted as good science right now.
Yeah. Okay, so how? We've established, depression's more than just an emotion. It's more than just feeling sad occasionally. How can people tell if it's time for them to see a psychiatrist or a psychologist because of their depression symptoms? What does that look like?
Part of the problem is that with a lot of mental health issues, that the patient themselves are suffering, but it's others that notice it probably before the patient does. Others notice personality or behavioral change, sleep disturbance, irritability, et cetera. So sometimes it's somebody else coming to your mom, your husband, your spouse, or your adult kids saying, "Hey, there's something going on here." So that's part of the problem, is that people sometimes put up a wall whenever somebody's telling them that there's something wrong and there's affecting them. Certainly, if if you're finding that you're not, it's not just not functioning, but it's taking a lot of energy to function. So certainly the obvious thing is if you're not able to make it to work, not to able to make it work on time, or school on time, those are kind of big markers. So there are certainly other things can happen. You can certainly have anxiety, and you can have addictions, other things that could make you not function in your day-to-day needs and your responsibilities. But if you're having a hard time, that's one of the first things that we have to ask about. Are you depressed? So that's very important to start there. And then the other piece that I found with my practice over time is that people can make it to work. People can, but they're exhausted. They barely can make out of bed. They drag themselves to get ready in the morning. They have to use a lot of caffeine and other things to get them going in the morning.
Yeah.
And they're just exhausted. They can do their work, but sometimes they have to push themselves, and they can't really do a lot of other things in their life that they want to do or have to do because their main responsibility, their kids or their job or school, just exhausts them.
Yeah. Are there physical indicators too, as well as like mental, emotional functionality issues?
Yeah, absolutely. So probably depression and anxiety are probably one of the big issues that we run into that cause a lot of our contribute to a lot of our chronic physical issues like pain, for instance, and headaches. But certainly people who are losing weight or gaining weight abnormally, abnormal to compared to what they're used to, we have to consider depression among a bunch of other metabolic and other clinical issues. So once again, it's very important for people who may be depressed to have somebody look for physical causes for depression, or what we call medical causes for depression. So people that are low on B12, people that are low on thyroid hormone or hypothyroid are classic textbooks reasons for become depressed. We just don't want to put those people on antidepressants. We want to treat their B12 or their folic acid deficiency or their thyroid issues.
Sure. So that wouldn't be a psychiatrist then. They would, it's an internist or family medicine.
That's a good point. The vast majority of people don't access a psychiatrist or psychologist right away. The vast majority of people who are depressed or feel like they may be depressed have end up seeing their primary care physician or their GYN, who's oftentimes considered a primary care physician. And so it typically starts there, which includes sometimes a physical exam, palpation or feeling of for the thyroid gland, make sure it's not enlarged, and checking thyroid studies, and CBC, complete blood count, which includes white cells and red cells and platelets, comprehensive metabolic panel, complete metabolic panel, which includes sodium and potassium, and kidney and liver function tests. So that's pretty basic stuff. So thyroid studies, B12, folic acid or folate, and CBC.
Those are to kind of rule out a medical cause of depression.
That's correct, and that's extremely important. It's not very common, but those are fairly correctable. There are causes, for instance, very rare causes. I don't want people to panic, but for instance, cancer of the head of the pancreas. This is even before people have abdominal pain. Can cause depression. So, and drinkers and non-drinkers. So it's important to recognize that we do need a physical exam and blood work at least once along the early part of diagnosing and treating depression.
So once we've had kind of that, ruled out some of those things with that consultation with our primary care doc or internist or whatever.
Yes.
What happens next with a psychiatrist? Like, what is the psychiatrist looking for, and what are they going to offer me to help with my depression?
Well, it's a good point that you jump to the psychiatrist, because the vast majority of people are treated by their primary care physician initially.
Oh, interesting. Okay.
Yeah, a vast majority of family practice physicians and primary care physicians such as internists and pediatricians and GYNs, gynecologists, OBGYNs are typically trained to initiate the safest drug and the most commonly used class of drugs, SSRIs, selective serotonin reuptake inhibitors. That's the Prozacs. Prozac came out in '87 in the United States. Prozacs and the Zolofts and the Paxils and the Celexas and the Lexapros. Those are the ones that typically are started initially. There are other reasons to start other products first, but it's not unusual to have a primary care physician do one or two or three different dose increases or different changing products before they say maybe it's time to see a psychiatrist.
So, so they'd try a couple of things first then. Okay, so once we're, escalated to a point that, we definitely need to get the psychiatrist involved, what more in-depth searching and discovering is the psychiatrist going to want to do with me as a patient, and then what are going to be their goals in my treatment.
Yeah, that's a good point about goals. And this, by the way, this is goals for as a general internist. This is goals for any chronic disease. Some diseases we can cure, a lot of them we can't. We tend to mitigate the negative effects. We try to get people to be more functional, even if we can't cure you. Cure for me is where you can stop the medicine, stop the treatment, and not have to see a physician or primary care or doctor or psychiatrist anymore, and you're fine. That's considered for me a cure. But the vast majority of people that get depression, the general principle is first episode of depression, if you treat somebody for 9 months with an oral antidepressant, 90% chance that they're, 50% chance, excuse me. So first episode of depression, oral treatment with the antidepressant for at least 9 months, 50% chance after you stop the medicine that they're going to relapse. 50% will do fine, not have relapse. If you have 2 episodes of depression, 70% chance of relapse if you stop the medicine, and if you have 3 episodes of depression, 90% chance of relapse. So the more rounds of depression, and a lot of people have been through multiple rounds before they even see the first practitioner to take care of them, first healthcare practitioner.
So is it pretty typical for depression to be a chronic condition that people have to manage their whole lives, basically?
That's correct, and that's the frustrating part. Obviously, is people don't want to have to pay for the money, don't want to have the side effects. Sometimes erectile dysfunction or decreased libido or weight gain that can happen with some, if not many, of these antidepressants. So it's very hard to continue taking something, especially if you finally feel good or feel good enough.
Right.
And some people want to stop it within a few weeks, but certainly the minimum is is 9 months of therapy. If we initiate an antidepressant for correct diagnosis of depression, the minimum treatment should be 9 months.
Okay, so you mentioned SSRIs. Can you give us an overview of what treatments are available to us through a psychiatrist and what things they might try first before we hit that treatment-resistant point? Yeah,
we want to differentiate. The typical depression does not need to come see people like us for ketamine. That's extremely important to differentiate. So the typical depressed person, so SSRIs, then sometimes the SNRIs, selective norepinephrine reuptake inhibitors, Effexor and Cymbalta, I'm using trade names, are oftentimes used sometimes as first line, or sometimes as second line after the SSRIs don't work. And then products such as Wellbutrin, which tends to work a little more on norepinephrine and some dopamine, can be added to, not just instead of, but can be added to one of the first 2 products. And then we, from there are several other classes, but then we start getting into non-traditional antidepressants, but atypical antipsychotics, the Abilifys and the Seroquels, that traditionally we would have reserved in the old days. The first generation of these we would have reserved for bipolar patients and for schizophrenic patients, but the second generation, or the atypical antipsychotics, we now use as add-on therapy to antidepressants to help people who have depression that's not responding very well to one of the first lines of antidepressants. I forgot to mention, before we had SSRIs, before the Prozac in '87, we used to have MAO inhibitors, monoamine oxidase inhibitors, and we also had tricyclic antidepressants. So these are old-fashioned drugs that did do quite well, but they came with quite a few side effects: dry mouth, blurred vision, urinary retention, constipation. But so that's why Prozac, when it came out, was a fantastic drug. Minimal side effects compared to the old drugs, and worked oftentimes just as well, not necessarily superior, and that's important to differentiate. It's not superior to the old drugs, but just had fewer side effects. The old drugs, if you overdosed on them, there was severe consequences. Prozac, very safe at high doses, and even if people accidentally overdose. Big difference.
So I guess before we get into, some of the treatments out there for treatment-resistant depression, we should put a plug in here about therapy. What's the what's the medical consensus about the role of therapy in treating depression?
It's interesting. I'm a humongous fan of therapy, and I think you are too.
Yeah, I am.
We've in our clinic. in our ketamine clinic that we've been running now for 6 years, a large chunk of my intake, whenever I sit down for about an hour and a half with a patient and their loved one, before we ever talk about give them consider ketamine, we sit and talk for an hour and a half to understand history. What I recognize, and after many years of as a primary care doctor prescribing oral antidepressants and antipsychotics, and then now with another tool, ketamine, I find that a lot of people have not done enough or the right type of talk therapy. And talk therapy, there's a whole range of talk therapies, but psychotherapy is a more technical term. But there's a whole range of them, and some of them are very, very specific. For instance, cognitive behavioral therapy for OCD and anxiety is exceptionally good, and also for depression. And a version of cognitive behavioral dialectical behavioral therapy (DBT), which is now being expanded to cover a lot of diagnoses, but also for personality disorders, borderline patients. That's been shown. So also exposure therapy, exposure and response therapy for people with phobias and OCD. So there's a lot of so there are very specific therapies that have good scientific evidence that we should either try first or try in conjunction with any of the medicines, including the orals and the ketamine.
Yeah. So what just generally, like, what would be the goals of therapy? Like, what are some general skills or self-reflections that are important to helping people be, successful during their treatment for depression? And I'm glad you keep bringing me back to goals, because sometimes I find that the patients, maybe the therapist understands the goals because the therapist is sending treatment plans to the insurance companies with short-term and long-term goals. But oftentimes the patient doesn't understand or see that or read that. So certainly the first goal, one of the goals is always about safety. Make sure the patient's not suicidal, right.
And that's very important. And believe it or not, if you ask the vast majority of patients, they will tell you if they are currently suicidal or have been suicidal or tempted.
Right.
So I think there's a big fear of asking people to fear that they may traumatize or shock the patient. Yeah. And it's really imperative that we, in the appropriate setting, the appropriate people, be able to ask a patient or potential patient. So that's the first thing. It's never been shown that asking a patient gives them the idea to try to commit suicide. So that's we should do a whole section on just suicide. We should do another podcast about that. That's extremely important.
Absolutely.
Especially now that there's a national number, which is 988. Yes, please. 988 is a national number anywhere in the United States. You call 988. I assume it's landlines and cell phones.
Yes.
Yeah. And you will, and that'll hook you into a hotline for suicidality.
Yep.
So therapy, first thing is about safety. Next thing is it delves oftentimes a little bit into your past. It depends on what types of therapy, about your childhood, et cetera. But a lot of therapy is focused on currently how you're functioning and the physical signs and symptoms, the mental signs and symptoms, and kind of coalescing these to help you understand how to get through your day.
Sure. Your coping skills, what you rely on.
That's right.
To get through it.
And it's imperative. I think why we see people desperately for treatment-resistant depression, oftentimes things have come to a head. Yeah. So there's kind of a semi-emergency, if not a true emergency. They're certainly sad and frustrated because a lot of things have stopped working or never worked. But there's a lot of functional stuff. They want to get out. They want to take care of their household. They want to take care of their kids. They want to take care of their job. They want to go to work. They want to enjoy retirement. So there's kind of this urgency.
Yeah. Yeah, I mean, that crisis point definitely drives plenty of people.
Yes. So
what kinds of research really goes into deciding like which of these treatments for depression are to be tried first, and then which ones are being pushed to a more treatment resistant level, and like why? How does that decision making process go?
Well, that's part of the frustration for sometimes payers and for other people is that if they see 3 different psychiatrists, let's pretend it's all the way to the level of psychiatrists, they will be started on 3 different drugs. Some people claim it's whatever drug they happen to have in their closet as a sample. from the pharmaceutical company. A lot of times, of course, it's not because insurance won't pay oftentimes for the newest and fanciest drug.
Yeah.
And there's a lot of, and people need to understand the vast majority of it's not true for every case, but the vast majority of drugs in psychiatry don't have superiority to other drugs that were previous generations.
Interesting.
So it's not that it's superior. Otherwise, you'd say, why use the old drug? Let's just start with a more superior, newer drug. But there are some superiority the claims that are FDA approved for select drugs, and I can't remember all of them right now. But the vast majority are not superior, but just sometimes have better side effect profile.
Yeah.
Once a day as opposed to twice or three times a day. So it's easier to remember to take.
Less weight gain associated with less weight gain as opposed to more weight gain. Those kinds of things.
So I should jump back. Talk therapists also tend to be the ones that establish the best relationship, the treatment patient relationship, or the used to be called physician patient relationship, as a therapeutic alliance. But it's oftentimes a lot of the therapists are a variety of degrees or certifications after their name. So licensed professional counselor, licensed clinical social worker, MSW, which is Master of Social Work, PhD in psychology, Psych D. So there are a bunch of different people with different educational backgrounds that do talk therapy, do it well.
And there's certainly some amount of education that those therapists have to go through to understand some of these neurological bases and how, and medications that are available for treatment, that kind of thing. Not that they can prescribe necessarily, but they're a good resource for patients to advocate for themselves with their psychiatrists or doctors as well.
Yeah, the biopsychosocial model, it's a biological, psychological, and social model, is kind of the preeminent way of thinking about mental health in the United States, probably in Western culture. So it's a biological. This is the brain circuits and neurotransmitters, and psychological. This is the emotions and memories and feelings and thoughts, and social interactions with family and outside society. So we, in some ways, people say, see, the old days, ancient times, people didn't necessarily think about the biological, but they thought about the psychosocial piece. And that was. So we're returning to some of those old ways.
Interesting. All right, so now we're gonna. I want to talk about. So we've seen our internist. We've ruled out some possible medical causes for our depression. We've seen our psychiatrist, who's put us through, a few rounds of different drugs. Dosing correctly. Can you talk to us specifically now about the definition of treatment-resistant depression? What qualifies as treatment-resistant depression, and then where we can talk more about treatments that are available for that?
Whenever I started looking 8 years ago, whenever we started thinking about ketamine, the easiest one is, as I mentioned before, let's pretend this is for an adult depressed patient who's correctly diagnosed for treatment-resistant, or is being depressed but difficult to treat, as they're not being as functional on medicine, or the medicines are not helping at all. Yeah. So at least 2 different drugs, sometimes in the same class, sometimes in different classes of drugs, for full adult doses, for probably several months, to make sure that they've reached blood levels, and to see if it can correct the depressive behaviors, the depressive thoughts and feelings and behaviors.
So we should say something there about the importance of if you're prescribed an antidepressant, you got to give it. You got to give it the old college try by taking it as prescribed for a specific, a significant period of time to see if it's going to alleviate those symptoms, right? You can't just. Yeah,
it's sometimes it tricks you. Sometimes you'll feel better for within a couple of doses of starting a new drug. You'll feel better within like a day or two, and you're like, oh my gosh, this is fantastic. But then it goes away, and so we're not sure why there's initial bursts. There's some theories about that, but then it goes away, and then you have to wait anywhere from 3 to 6 weeks to see the benefit of that dose. And so it's not unusual for a physician or psychiatrist to say, please call me in a couple of weeks, but I'll see you back in 6 weeks. We want to make sure that you don't have adverse side effects, because as we say, side effects come before benefits. So if you're going to get dry mouth or be too sleepy or et cetera, it tends to come very quickly. It doesn't have to build up, whereas the benefit tends to have to build up over time.
That's good to know, to manage those expectations, right?
That's right. Yeah. A lot of people are on the phone. They hate it from the day, they barely have taken the first pill and they're already on the phone complaining that they can't take take this pill. People have to listen. The medical professionals have to listen. But if you warn people, they tend to be understanding. And oftentimes you have to have people hand out information, not just tell them verbally. Hand out information because people sometimes can't hear everything whenever they're super depressed.
Yeah. I mean, just like anecdotally and personally here for a second, that was like that was a big turning point in my personal treatment process, was making the conscious decision like, okay, it's frustrating to have to try lots of different meds, but I'm going to take my medication every day exactly as it is prescribed, because it rules out a variable, right?
That's right.
Like if I know that I'm taking it every day exactly as it's prescribed with the right dose, then I can tell my psychiatrist, they'll know, is it helping me? Is it not helping me? We don't have to worry about there's an unknown variable of usage, right?
That's correct. Yeah, that's one of the frustrations is that on average, this is medical practitioners, nurse practitioners, psychiatric nurses, physicians want to please the patient. They want to help the patient.
Sure.
And the patient calls, and every time they call, the physician, nurse practitioner, or PA keeps changing the dose or keeps changing the medicines. We really never know what really would have worked.
Right.
As opposed to spending more time to sit to figure out what the patient's worried about or what they're afraid that's not going to happen or is happening.
And likewise, if the patient isn't taking it as prescribed, they're not going to.
That's right.
They're going to be making those changes. With really no end in sight. Yeah, absolutely.
And it racks up a big bill. I mean, it's better to sit down and talk than to keep changing medications, because every time you get a new medicine, you have a new copay, and it sets you back a little bit of time, et cetera, because you have to start all over again. And then, of course, on average, you tend to start with less expensive medicines that work.
Yeah.
They've been around since the late 80s, sometimes earlier. And then if you go through one or two classes pretty quickly, then you tend to get the more expensive classes of drugs that your insurance doesn't want to cover or has a higher copay.
Yeah. Okay, so we said two drugs then, right? Talking about treatment.
Yes, at least. And the vast majority of the patients that come see us, of course, not have tried, many drugs. I won't say dozens, many dozens of doses and combinations. People forget that it's not unusual to be on 2 or 3 different antidepressants. Not usually 3, but 2 antidepressants plus an atypical antipsychotic or sleep medicine or anti-anxiety medicine. So it's not unusual to be on, 3 and 4. This is even for depression, anxiety, or insomnia and depression. It's not unusual to be on 3 and 4 drugs pretty easily. And this is, people say, oh my gosh, this is too many drugs. But whenever you look at how we got there, there is a logic behind it.
Sure, absolutely. Okay, so then once we're firmly in this, category of treatment-resistant depression, what are the available treatments out there for that? Yeah,
in the United States, the 4 FDA-approved treatments. The Food and Drug Administration has FDA-approved treatments for 4 different ways of treating treatment-resistant depression. The tried-and-true old-fashioned one is ECT, electroconvulsive therapy. Unfortunately, it's gotten a bad rap from movies, et cetera, but that is the stuff that saves lives when nothing else will work. Yeah. This is the stuff that will give for severe postpartum depression, or people who've had a heart attack and are severely depressed. ECT is safe in these situations.
Why is it safe in those situations?
Yeah, people think that electricity passed through your brain is harmful but it turns out that we've had decades and decades of experience and research to show that this is safe. We not sure exactly how it works. It seems to reset the brain. Sometimes the pills that didn't stop working for depression after ECT seem to work again. We don't fully understand why, but certainly that's still the gold standard. It's only because it's the gold standard because it's been around for decades. Yeah. But like
it's a non-chemical treatment, right?
That's correct. It's non-chemical. That's right. You have light sedation, and you either one side of the head or both sides. So bitemporal, unilateral, bitemporal ECT. Bilateral is typically for more severe cases. The biggest side effect typically is memory issues, which is a significant issue. Mm-hmm. So usually unilateral is less memory issues. Bilateral tends to have more memory issues. And the memory issues tend to improve after you stop ECT, but there's oftentimes a small gap still that people have in terms of their memory.
Okay. All right, ECT.
So the next one is
104.
TMS, transcranial magnetic stimulation,
Right.
and that's a magnetic therapy. Unlike ECT, where you're sedated and you have to have a driver, TMS is usually 5 days a week for about 30 sessions. And that's you can drive yourself to and from, no medications, and this is using pulse magnetic therapy, also pointed at different parts of your brain. Sometimes it's repetitive, sometimes it's deep, but anyway, it's we're not exactly sure how that works also, but it also seems to do kind of a hard boot or hard reset. And that can be used with, all these can be used with medications. Oftentimes they are used with medications and stuff like that.
So TMS is kind of informed by that new school of thought, right, about depression, about what causes depression, you know, the different levels of activity in the pathways of the brain. Yeah.
That's correct. There's certain sections of the brain. So ECT, TMS are FDA approved, and then Spravato came out about 4 years ago. It became available. It's the mother compound of, it's a daughter compound of ketamine. It's called S-ketamine, ES-ketamine, and so it's called Spravato.
What's a daughter compound? I need a definition on that.
It's made from the mother compound. So there's a right and left side to the ketamine molecule.
Okay.
They decide that the right side gives you side effects, too much dissociation and stuff like that. So they do the S or sinister, in Latin is sinister is left side. Okay. So they kind of make it called ES-ketamine.
Got it.
So it's the left side. So that's why I call it daughter compound.
Okay.
Anyway, so it's supposed to be a cleaner drug. It's a nasal spray, and it's done in the doctor's office. I think it's a 2-hour sit in the doctor's office. Insurance is starting to cover it, et cetera, and that's also FDA approved. And the final thing that if I remember correctly, is vagus nerve stimulator. This is something very special. I've not seen it in our patients, but they actually put a lead or a wire around your vagus nerve. A vagus nerve runs from the base of your brain down all the way down through your neck and into your chest, into your pelvis. But the vagus nerve, if you run electricity through it through a pacemaker, essentially, so they implant this as a surgical procedure. If you stimulate it, the vagus nerve, it can potentially help severely depressed people. Also,
wow,
there's some other non-FDA approved things, deep brain stimulation, some other things, but these are the 4 FDA approved things: ECT, TMS, Spravato, and VNS or vagus nerve stimulator.
Okay, so now that we've covered those, it's pretty much time to get to ketamine infusions.
Sure. Yeah.
Let's talk about it.
Yeah, I always start out talking with my patients. I say ketamine's been in the States, United States. It was developed in Europe. It's been in the United States since about the 60s. It's actually FDA approved only for one thing, is for anesthesia, and that's not how we use it in our clinic. We use it at sub-anesthetic doses. So it turns out that years ago, people accidentally found out if you sedated people, the use of the FDA approved use for it, and they woke up after their surgery for their gallbladder or whatever, they would be less depressed if they had depression before, or less anxious, or less neuropathy. This is another thing we use it for, is for chronic pain. So it wouldn't last very long, sometimes days to weeks, but these people would feel better for other conditions. And as people started saying, do we have to sedate somebody and put them on a ventilator while, in order to get them less depressed? And the answer is no. You can do small amounts repeatedly in the office setting, either IM, intramuscular, or IV. You could do small amounts for a certain amount of frequency, and you can get a benefit for treatment for treatment-resistant depression. It's not a cure. It's not FDA approved. We can use it off-label. It's very common and very legal in the United States to use something, the drug that's not FDA approved for a condition that the physician deems necessary. But we can dig people out, what I call dig people out of their darkest holes that nothing else seems to work for. And some of our patients see us before they get ECT. Some of them see us after they had ECT or TMS.
Yeah. So just to back up, ketamine has been used in humans for quite a long time. I think a lot of people are probably familiar with ketamine as a horse tranquilizer, something you might find in your veterinary office.
That's
and
right.
then also that, would be a club drug,
That's right.
In the 90s or so.
Yeah, it's, unfortunately everything makes it out on the street eventually. So ketamine is a Schedule III drug. The Drug Enforcement Agency put out a schedule starting back in the 70s. They scheduled it as their Schedule 1 through 5. 5, I believe. And Schedule 1 is drugs that have high addiction potential with no medical benefit. And so this is a Schedule 3 drug. It's in the codeine it's not in the codeine family, but it's in the codeine level of scheduling. So it has some potential for addiction. In our clinic, we don't prescribe it for anything outside the clinic. We don't give prescriptions. We only deliver it inside the clinic.
Right.
But it did start out as a vet med drug, a veterinary medicine drug, also for animal anesthetic, horse tranquilizer, and stuff like that. But a lot of things in vet med work for humans and vice versa, and, antibiotics and all sorts of stuff, so non-steroidal. So anyway, yeah.
Sure. Okay, so then you talked about we use ketamine on an off-label basis to treat this. Can you give us an example of another drug that and an off-label usage and kind of how that relationship works together?
Yeah. Common use, for instance, let's say gabapentin. Neurontin is the trade name. It's gabapentin. It's an anti-seizure drug, but we rarely use it for seizure treatment in the United States. The vast majority of the time we use it for neuropathy, for nerve pain.
Interesting.
So we use it for that. We actually also use it for anxiety treatment. So we can use it. So it's not unusual to use a drug for multiple different purposes that the FDA or the manufacturer never intended it.
So if it works, gabapentin, for example, if it works to help with neuropathy, why hasn't the FDA approved it to be used for neuropathy?
Yeah, that's good. Well, it turns out in the United States it's really expensive to do all the studies necessary to meet FDA approval,
right?
to get the appropriate approval. So
there's some political and bureaucratic aspects to that organization.
There's a lot.
Yeah.
It takes time and money to do the right studies, and if it's already out in the community and FDA approved for select things, fortunately, we're legally allowed to use it for any other condition that we deem fit and necessary.
Okay, interesting. All right, so let's get back to ketamine a little bit more. So, what does a course of treatment look like? What kind of benefits can people expect to see?
I'll talk about the IV delivery of ketamine, the intravenous. So typically, somebody who's treatment-resistant depression, most of our treatment-resistant depressed people have multiple other conditions alongside. They have OCD or anxiety or PTSD or panic. So it's not unusual to have multiple other things that ketamine may help. But for treatment-resistant depressed patients, our protocol at the Midwest Institute for Hearts and Mind is that after you meet with me for roughly anywhere from an hour to 2 hours, oftentimes with a partner or loved one, so I can get corroborating information. And oftentimes these people are sent to us by their physicians or practitioners. Some people come to see us by word of mouth, but they already have primary care doctors or psychologists or talk therapists. So they have somebody on the outside of our clinic that is helping manage their medications and their talk therapy, et cetera. Right. For us, we look for 6 infusions over 3 weeks. So it's twice a week for 3 weeks. So we call it contiguous so that we don't try to take a break. So it's twice a week, twice a week, twice a week. Each infusion is 40 minutes, 40 minutes. There's some time beforehand to prep you, some time afterwards to recover. So oftentimes you're in the clinic for about an hour and a half total, but only 40 minutes are actually in a recliner with an IV in your hand, quiet, dark room. Sometimes you bring your own headphones. So sometimes you're watching a nature channel, but it's a quiet time. And because it's a dissociative anesthetic, sometimes I call it a loopy, goofy feeling. You may see this room distort, colors to become more intense, noises to become more intense. And it's not really frightening at all because my partner, Dr. Frugi, explains all this to you. You can have a loved one sit with you in the darkened room. We can go up and down on the dose. We have a rising dose protocol. We increase the dose with about 4 times during 6 sessions, but we were flexible depending on how you respond, how you feel afterwards, et cetera. So very safe drug. Has been around for decades. They use it on pediatric patients. They use it in the military, out in the field. These are IV, intramuscular for emergencies, for sedation and pain control. So it's used throughout the world, and it's very safe. especially in our hands.
Yeah. So who administers it at our clinic? Talk about the expertise that's required behind delivering these treatments.
Sure. We've chosen, 8 years ago, Dr. Farugi, my business partner and my co-founder, Dr. Vafa Farugi, and I chosen the medical model of physicians, nurse. So we don't do a spa. We don't do anything else you would recognize this as an infusion center, like you would if you were to go receive blood or receive chemotherapy. Recliner, comforters, monitors, a physician within a few yards of you, et cetera, et cetera. So all the safety protocols that anybody would need, because we do see a range of people from 15 all the way up to their 80s.
Yeah, absolutely. So does the expertise require in the environment that people are in, does that kind of explain some of the expense factor? Because ketamine infusions are expensive. Help us understand more about why that is.
Yeah, because it's not FDA approved, insurance tends not to want to cover it. They consider it experimental, even though it's been around for decades. So people typically it's a cash pay. Some people are able to submit a super bill to their health spending account or medical savings account,
right,
and get some reimbursements. So that's for the IV. And yes, because you have a physician and a nurse, Aaron, and the amount of time in the office, that's where the expense comes from. Yes, that's correct.
Sure. Yeah, I mean that's certainly something for people to consider, right? I mean, those are all part of the pros and cons list of considering any of these treatments for treatment-resistant depression, figuring out the right fit for you.
Right.
You also talked about starting off with a consultation in our office, so you have that long interview basically with the patient to help them set expectations and help them understand how the treatment is going to go. What would you say, leave us with something hopeful about where treatment is going for resistant depression and other mental health issues?
Well, so although ketamine is not considered a psychedelic, it does give us dissociative or kind of a little bit of a psychedelic experience.
Sure.
Yeah, it's a little bit of a psychedelic experience. It's very super controlled, super tightly controlled compared to what people may hear about and stuff like that. But across the world, but especially in the United States, let's talk about the United States, from the National Institute of Health, from Johns Hopkins, from Yale. Not only do we have ketamine and MAPS, which is an organization out on the West Coast. Not are we dealing with ketamine, which is FDA approved, FDA is legal in the United States, but now they're doing at university setting and big research bigger and bigger research studies for MDMA, which is ecstasy, for psilocybin, which is magic mushrooms. So we're looking at more and more hallucinogens that for a variety of conditions, not just treatment-resistant depression, but post-traumatic stress disorder, end-of-life depression, and addictions. There's some excellent work in terms of tobacco addiction and alcohol addiction, and being true and very brief therapy treatment with psychedelics, helping people dramatically.
Yeah, because we think that obviously those drugs don't act on serotonin receptors or anything like that.
That's right.
So we think that there's something therapeutic in this experiential type of treatment. We see that with people experiencing dissociation with ketamine too.
That's right. Unlike Prozac, where it doesn't matter what you drank or ate last night, if you slept or not, you take your Prozac, you'll feel the same way. Ketamine is and all the psychedelics. There's mindset, right, and setting, the room and the physical space, and then dose. So those are the three things that kind of determine experience: mindset, expectations, etc., and setting, and where you experience the treatment, the safety, the professional setting. What we hope makes a big difference for us, and then the dose.
And so I've heard you make this prediction before, but say, how do you think this is going to change the face of mental health care over the next, whatever time frame?
Yeah.
What are we looking at in terms of years?
Yeah, I believe it's going to be relatively short term, within the next less than 5 years, that we're going to see psychedelics that and not always FDA approved. Once again, this is the tricky part.
Right. The bureaucracy moves slower than the science.
That's correct.
Right?
Yeah. So I think that I know people already. Some of my patients are already talking talk to me about some of the other experiences that they've had, et cetera, that they've done on their own,
Sure.
et cetera, sometimes within the U.S. borders, sometimes outside the U.S. borders. But I believe that we're going to have a kind of an explosion of treatment options, and not everything is necessarily going to be depending on what the FDA does and what and other and our Justice Department, our legal system does. Some of the stuff is going to be not in the physician's office, not in a medical setting. So it's exciting and scary at the same time.
Yeah, absolutely.
But I think that we're going to have more options for people. And my hope is eventually the King of the Mountain, ECT, for instance, will be appropriately dethroned by other products that are as effective, if not more effective, and safer.
Yeah, absolutely. I mean, that really inspires a sense of hope. I hope our listeners are feeling hopeful after hearing all of this information too. There is so much coming on this new frontier for mental health treatment. Obviously, we want to wrap up today by just saying, if you have depression, if you think you have depression, please reach out to your primary care doctor. Please establish a relationship with a doctor that can help you rule out those medical concerns that might be attributing to, your condition. Take your meds as they're prescribed, right? Do the things that that you can do to help yourself. And if you're experiencing something that you think is treatment resistant, there are other treatment options out there. Dr. Tadros Listoff, ECT, TMS, Spravato, and the
vagus nerve
stimulator.
That's right.
Not a doctor here. Yes. So, but then, ketamine could be an option for you too. So, you can reach out to us where the clinic is available online, MidwestHeartsandMinds.com. You can submit an inquiry there and I can reach back out to you and give you some more information. There's lots of studies, information about our treatment process and protocol on the website as well. And there's just hope. Don't give up.
There is nothing in the textbooks. I tell my patients, and I had a tearful mom the other day with her teenage daughter. I said, there's nothing in the textbook to say we give up on people because they failed, X amount of trials or X amount of medicines. There's nothing that says we give up on people with this addiction or depression or anything else like that. Yeah. Now, I want to make sure that people understand. It doesn't mean that we're going to get you an answer or therapy as fast as you want, as fast as you need. But there's always hope. The other thing I should always ask, because we talk about medicines and drugs and stuff like that, lifestyle, connection with loved ones, connection with a purpose, sometimes called a higher power, higher purpose, are incredibly, incredibly important. And we're going to talk more about that. That's exciting stuff. That's you and I think you and I enjoy talking about that.
We do enjoy talking about that stuff. All right. If you want to get involved with the pod or send in a question to Dr. Tadros, you can email us at notyourdocpod@gmail.com. That's notyourdocpod@gmail.com. We're going to see you guys soon, and we'll be talking more. Thanks Dr. Tadros.
Yeah, thank you, Vanessa. It was fun. Thanks.
Yeah.
This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.